It right now is 4:42, and so as the moderator and the one who's supposed to give this talk, I'm going to cut it in about half. So I apologize if it runs a little, feels like it's running a little fast, but I want to make sure that you all get to the more important talk, which will be the gentleman who's following me. So let's talk about a topic that I get questions about all the time. And I got to tell you, as someone who's been doing like research on prescribing and pain management for the last 5 years, one of the things, anytime I present on like opioid use after surgery or anything like that, people say, well, yeah, what about chronic opioid users? All my patients already use opioids, so my patients are different. And so I think it's an important topic for us to talk about. Here are my disclosures. None of them are relevant to this talk, and I think it's been up there for 7 seconds now. So importantly, it's very important to understand that there's a big difference between chronic opioid use, opioid dependence, and opioid use disorder or opioid abuse and addiction, okay? And sometimes I feel like giving these talks, especially meetings like this, it's a little bit of an echo chamber because maybe everybody in this audience knows it, but I guarantee you most of your colleagues do not. Okay, so it is a very big difference to say a patient has a prescription for an opioid or has had a prescription for an opioid, and the patient is dependent on those opioids. And it's a much even bigger difference to then say and code that the patient has an opioid use disorder. One thing that I have seen in the literature, and somehow it gets to publication, is, oh, we looked at everyone with opioid use disorder to look at the effect of chronic use. And those are completely different things. And if a patient comes into you and they are on chronic opioids, let's say for their low back pain, and they've been on it for years, please do not code that they have an opioid use disorder and put an ICD-10 code on that, because that's the other thing that I see a lot. Just because we have an interest and we're talking more and more about opioids, it's important to know the difference. So the definitions are up there, and I think it's probably the most important part of the talk, so I'm going to just keep that there for a second, which is that the CDC has a definition saying that receiving an opioid on most days over a 90-day period measured by 45 or more prescriptions in 90 days after injury, that's chronic use. Okay? And it does not imply or diagnose dependence or opioid use abuse. Dependence is really a physiologic diagnosis. It means that if you remove that stimulus, that the patient will have withdrawal symptoms. And again, it's a physiologic diagnosis. So it does not mean that that patient is going to go out and steal or do other things that would be adverse events, okay? That is abuse. That means that they're doing things that they have an inability to control their use, that they're seeking it out and doing, and it is an abnormal variation. So all three of those are very different. Most people who have chronic opioid use because they're being prescribed it are not necessarily dependent, and they certainly are not abusers. I think I've harped on that enough. So why should we care then? When people say, okay, so if you're doing opioid use and you're looking at pill counts and you're looking at prescribing and you're talking about managing, how do we manage our patients, why should we care about it? We should care about it because there is a potential for an increase in pain response or dependence or that physiologic effect. If the patient has never been on opioids, they don't have that. So by definition, if they are chronically on opioids, they're going to have a higher risk of having upregulation of the receptors and all the things that Dr. Kurpada talked about. And so we may have to treat them differently, and we should know that and think about it. The next is that patients who have chronic prescriptions for opioids have a provider who is managing that chronic prescription, and so therefore you need to take a second and think about the care coordination that probably has to go into that. If that patient continues to have pain afterwards or things like that, like who is going to be managing it? Is it you? Is it the provider who's managing their chronic pain and their chronic opioid use? And the last is within that subcategory, patients who are chronically on opioids may have a higher risk of opioid dependence, and that's particularly important after 6 months. So there are lots of studies on this. I'm not going to belabor it, but really you don't see much dependence, if at all, within the first 6 months. And so if you are seeing dependence, it's on patients over 6 months. So chronic opioid use just means 45 days or more within 90, not up to 6 months. I'm going to touch briefly on a study we did with the American College of Surgeons and a company called Get Well Loop. I'm not affiliated with them at all. It was a pilot study. But what we wanted to do is we wanted to look at a lot of these more difficult questions about opioid use. You'll notice in the literature, almost all of the literature is focused on prescribing, and then they assume use. But use implies that the patient is actually taking the medication. That's very different than a provider saying, here is your prescription, take them if you need. We enrolled patients over a 2-year period from 2018 to 2020. It had an IRB review, and we had pre- and post-op questions. It was all automated. And what we were doing is we were querying patients on intervals to get at actual opioid use. And we looked at pain interference scores and excess pills and disposal. I know I'm flying through this, but I do want to make sure that the talk is short and sweet. And so we had about 10,000 patients. Of that, we had close to an 80% response rate of continuous answers. And within that, we had what you would say is about what everybody else sees, which is 80 to 85% of patients actually use the opioids. So patients are responding, but they're saying, oh, I didn't actually use the opioids I was prescribed. And here's the punchline. When you look at naive patients and chronic users, the two big questions that you may have are they going to have higher pain scores? Are they going to perceive a higher level of pain from the same operations? And are they going to take and need more opioids? And the answer is yes, maybe, but slightly. So this is our data, and you can see there are two y-axes. One is number of pills used, that's the black line, and the yellow line is PROMIS pain interference scores. And you can see they are very well mimicked. So most of the pain, as has been shown many times over, happens in the first 48 to 72 hours. There's that peak, and then there's a runoff. And that the peak is a little bit higher in chronic opioid users, taking more like 7 pills on average rather than 5. So interestingly enough and well-timed, a press release just came out on a joint statement that was the Anesthesia Society, the ASA, America's Anesthesia Association, got together 14 other organizations, of which the American College of Surgeons and a whole bunch of other professional societies were part of, and they convened a retreat to come up with best practices guidelines. This is the press release. If you'd like to try and scan the QR code, it'll take you right to the press release and then link you to the article. And they were specifically talking about what are our best practices guidelines for complex pain management. So patients who are either chronic users or have opioid use disorder or have abuse and addiction histories. And in those patients, they had 7 main takeaways, 7 best practices guidelines. I've pulled out the 2 that I think are most relevant to this particular talk about chronic use. And that is for patients with long-term opioid therapy preoperatively, so when they come in with known chronic use, it's very important that clinicians coordinate with the patient's provider and that you continue the baseline opioid use. So this is an excellent segue to say, if they're taking certain level of opioids for their back pain and now you give them belly pain, you're treating the belly pain, but they still need treatment for the back pain. And so keep them on that regular dose and treat the additional pain that would be caused by your particular procedure. And I think that's really important as you're thinking about care coordination, is the pain that the patient is now experiencing, are the problems that they're having, are they directly related to what you just did in your surgery, or are they related to the overall chronic management issues that are associated with pain management and opioid use? The second is that clinicians should work with patients who have opioid tolerance. So a subset of patients who've been on opioids for a long time, these are especially patients who have seen dose escalation over time. They maybe have increased tolerance. Those are the patients that probably require more opioids than your average patient around the time of surgery, and they may need a longer taper. And so it's very helpful to talk with other clinicians that help manage that, other pain management doctors, your anesthesiology colleagues, and others to say, what is a good individualized plan for this particular patient? And so those are their 2 main takeaway points. And so in conclusion, I would say that my main takeaways when you think about treatment of patients who are have chronic opioid prescriptions are to know the difference between chronic use, dependence, and addiction, and make sure that you do not conflate those. Coordination of care is critically important. It's a diagnosis just like their obesity, diabetes, or anything else that another provider is probably managing, and you want to know how that interacts with what you're doing and how you make sure you don't overstep your management and you treat the patient as best you can. The next is that most tolerance or dependence really happens after 6 months. So if someone's an intermittent user or they have only recently started on it because of the pain that was associated, let's say, with their hernia, and it's only been 2 or 3 months, you aren't really worrying about those increased tolerance issues. Those who do have an increased tolerance or dependence, however, may need an individualized taper, so please think about that. And in the national cohort study that we had, there was really minimal increase in opioid use in the chronic opioid users, and there was really minimal increase in pain response. So although there was an increase, it was very minor. And I will just end with something that I always like to end with on talks like this, which is that it is shocking to me how infrequently we still monitor and know what's going on post-operatively with the pain management. If you go into post-op notes 30 days, 60 days later, it's very rarely asked and documented, did you use your opioids? How well was your pain controlled? What did you do with them afterwards? If we're gonna continue to grow and understand opioid use and and how we are best managing our patients, we have to ask those questions and we have to be more involved. So I know that was very fast, but I'm very happy to answer questions afterwards, and I hope we have an opportunity to get to the question and answer period at the end.